Okay, good morning, everyone. It's great to see you all here. Thank you very much for joining us. My name is Paul Middleton. I'm a Managing Director within Protivity, and I'm joined today here by my colleagues from Protivity as well as my colleagues from our sister company, Robert Half. As many of you know by now, particularly, this is our weekly collaboration forum, a forum for us all to collaborate and learn from each other. We started 19 weeks ago by collaborating around the disruption caused to our businesses by COVID and looking at how we remain resilient. And over the last few weeks, our focus has shifted. We've talked a lot more about how we approach the future. And in particular, we've been discussing how we should reimagine our businesses before we leap into business as normal. Our aim, however, has remained consistent. And we hope that by hearing the forum insights, innovations, and perspectives, you'll be able to join the dots to your own challenges, which will help with your decision making and give you greater confidence to make the right decisions and make them quickly. Last week, we had a great discussion around how our regions and regional businesses are recovering and performing. And this week, I'm very pleased to say we're turning our attention back to a topic we talked about at the very beginning of our forum, healthcare. Over the last 20 weeks on this call and on similar forums that you probably have all attended, we've spoken about our business resilience, our business challenges, our business successes. But I think it's probably fair to say that most of us have been a long way from the true eye of the storm, the front line of COVID, and we've been one step removed from working in a world where COVID is ever present next to you. So we wanted to give you some insights today from the front line and look at healthcare again, but not just COVID related healthcare. Instead, we wanted to bring you more of a focus on the impact of COVID on the wider healthcare system and the care system, and talk about topics like the impact of the last 5 months on the treatment and funding of other ailments and diseases, especially cancer, how the healthcare sector is coping with the management of non-COVID related ailments, the impact on cancer charities and the work that they do, as well as the application of data science and AI to better manage and predict caseloads, a second spike, another pandemic, and hopefully better prepare ourselves for whatever lies ahead. So I'm delighted to say that we have some wonderful panelists today who'll be able to unpack some of these themes and provide us with insights into their world, and I'll introduce them shortly. Before we kick off, a little bit as normal on forum logistics. We have over 60, 70 people here today who are clients, friends, and partners on the call this morning. Most of you, if not all of you, are connected with Protivity or Robert Half in some way. And for those of you who don't know us at Protivity, we are a change management consultancy. We focus on technology, risk, and internal audit. And we specialize in managing risks in your business, changing your business, and helping you face the future with confidence. And so in partnership with Robert Half, we deliberately have brought a wide audience on the forum today, as with every week, from diverse industries such as financial services, charity, manufacturing, food, public sector, retail, technology, hospitality, media, sports, and many others. As we think this is a forum where you can all learn from each other and hear those different perspectives. So this is your forum. So please share your perspectives, ask your questions, disagree or agree with the panelists, give your points of view, but please interact to make it as useful and meaningful for you as you can. You can do that in a number of ways. You can speak up, you can ask a question. Just please, I think everyone is probably currently muted, but you can unmute yourselves and do that. For those of you who are on the phone, you'll probably need to press *6 to do that. You can also click on the Teams taskbar and ask a question through either putting up your hand and I'll come to you, or by just writing a question in the sidebar, as many of you prefer to do. So we'll also, as with other weeks, be having what we've called an after party, where we'll keep the line open after 9 o'clock. And for those of you who can join, we'll be delighted to see you there just to continue the discussion. And so, yes, we look forward to speaking with you all throughout the next hour. So now to introduce our panelists. Our first panelist is Rajesh Nair. Rajesh was appointed a consultant urological surgeon at Guy's and St Thomas's NHS Foundation in 2017. He cares for patients with all urological malignancies and has a specific expertise in the investigation of bladder, kidney, and upper tract urothelial cancer, and performs a range of diagnostic and surgical treatments for these conditions. Raj has a special interest in open, laparoscopic and robot-assisted surgery with a particular focus in bladder, kidney, prostate and testicular cancer, as well as reconstructive surgery. He's completed 3 advanced fellowship training programs in robotic, uro-oncology and reconstructive urology, and is a leader in his field. I'm delighted to say that our team at Protiviti have worked with Raj and his fundraising team on a number of initiatives, which we've been honoured to do, and we're delighted that he can join us today. Next, I'd like to introduce Bob Andrews. Bob is Chief Executive at Benedine Health. Benedine Health is a mutual society in the UK providing private medical cover to a membership base of over 800,000 individuals and employees of corporate schemes. With over 650 employees, Bob is responsible for leading the development and execution of the company's strategy and commercial objectives. Prior to Benedine, Bob was CEO of Capital Home Loans, Head of Operations at Direct Line, and Head of Commercial Sales at RBS. And we're delighted again that he can join us today. Next, I'm pleased to welcome Trish Morgan and Jess Ruth from Maggie's Cancer Care. Maggie's, as many of you will know, is a charity providing free cancer support and information in centres across the UK and online. Built in the grounds of NHS cancer hospitals, Maggie's centres are warm and welcoming and designed to be special places. They're run by expert staff who help people live well with cancer. The first centre opened in Edinburgh in 1996, and Maggie's now has 23 centres in the UK, with more in development. Trish is the centre head for Maggie's in Oldham, where she's been since 2018. She's a qualified nurse with a career in the NHS for over 30 years and was a specialist nurse in her local trust for 20 years in the area of colorectal cancer surgery and research. Jess is the centre fundraiser at Maggie's in Manchester, where she's been for 2.5 years. And Jess is responsible for coordinating and fundraising activities at the centre. Maggie's isn't part of the NHS, so all the centres and activities are funded by voluntary donations. And we're delighted to welcome them both to our forum today. Next, I'm pleased to welcome Neil Murray. Neil is CEO at Impact Data Metrics. Impact Data Metrics uses proprietary technologies to provide data-led insights across property and economic development, healthcare, research and innovation. Neil and his team collect, clean and organise data to ensure their clients use the highest possible quality data sets for their own analytics. And it's within the domain of healthcare, research and innovation that Neil is going to be speaking today. Neil is an experienced biotech and technology industry executive with international experience in drug development and data science. And prior to Impact Data Metrics, Neil has founded and run a number of large and public biotech companies. And again, delighted that Neil and all our other panelists can join us today. So thank you. So Raj, I'd like to start with you, if I may. And I know you're going to show some images on the screen if technology and Wi-Fi permit. But Raj, with the world's attention and medical resources having been focused quite rightly on COVID over the last 20 weeks or the last 5 months, but in that context, there are almost 400,000 new cancer cases in the UK every year. And so from your perspective, what's been the impact of the last 20 weeks on cancer care? And how are you approaching what is probably then a backlog of patients and a backlog of people requiring life-changing procedures?
Absolutely. So first of all, thank you so much for having me. Real honor to be able to speak to such a different and diverse forum. And I hope what you find what I say is going to be useful for you all. And thank you particularly for all the support that you've given us through all the charitable work that you've done. It's been an interesting period of time. My week normally would have consisted of a very regular operating list on a Monday, an operating list on a Tuesday, a clinic on a Thursday, an operating list on a Friday, and half a clinic on a Saturday. And that would be pretty routine for me, and I would be able to schedule in patients as and when I want to. And then COVID struck, and it's amazing how much can change in such a small space of time. And I'm sure you've all experienced it, and certainly in healthcare we've seen it as well. Suddenly, all our anaesthetic colleagues who were down on the front line, essentially putting people to sleep and helping us with the surgical cases, have been taken away to help man intensive care units, which have sprung out of nowhere. Particularly at Guy's and St Thomas's Hospital, we've managed to create over 350 beds in every nook and cranny that we can possibly think of, using ventilators from our operating theatres. This leaves us without any physical operating space or operating theatres to do routine work. And it's meant that we've had to really, we've had to take a step back from pretty much most elective operating. And even till now, we've really are playing catch up with the elective operating. Yet we're a major tertiary teaching hospital and an academic centre in the centre of London, and we're not just responsible for our catchment areas of Lambeth and Southwark, but we're a tertiary referral centre from other places in the UK as well as internationally. We see patients from all over the world who need a second or tertiary opinion. And so you have a huge number of patients who would not necessarily have any treatment locally that need to come and seek out us for whether it be surgical or oncological expertise. And private hospitals who've been fantastic in providing space and operating capacity and their staff to us. And in fact, sitting right now in a private institution where we're doing national health cases. And we've gone from 54 theatres across our trust down to about 10 theatres, and the throughput is still the same, and it becomes difficult, because then you're faced with a situation whereby you've got to ask yourself the following question. You've got people on your waiting list with urgent cancers. You've got your mother or your grandmother, who is an incredibly high-risk individual to undergo an operation whereby we know that surgery, and major surgery in particular, drops your immunity. And if you were to suffer from COVID, the mortality rates are incredibly high. If you're over the age of 80, the mortality rate from COVID with surgery is in excess of 80%. You have the top right image here, which is a huge kidney cancer, and left untreated within about 3 or 6 months, this can result in spread, limiting the length or quality of someone's life. The little image below that little bit of coral there, is a bladder tumor, and that's a bladder cancer. And whilst the bladder cancer itself may not necessarily be dangerous, they bleed. And so people bleed, and they require blood transfusions, or they can cut off in their bladder and require a catheter. And so suddenly you're in a position where you want to prevent the sequelae of cancer. And so you need to operate and remove these things before patients suffer. And below, you've got that, there's an ultrasound picture, and that ultrasound picture shows the right testicle. And this is actually a 20-year-old gentleman who works in the city. And he needs to have an operation to remove his testicle for cancer. And otherwise, the doubling time for these tumors is about 10 days. So you've got a varied number of reasons as to why you would need to operate on people, either because their cancer is life or threatening, or it imposes a significant threat to their quality of life, or people are very, very anxious. And what's been interesting is, since the lockdown has been lifted, the number of complaints that have come through to our sort of patient and advice and liaison team have skyrocketed, because people now want to have their operations, and yet we're still working on restricted capacity. And that leaves us with this, a very difficult dilemma. And we've done well. And do ask me questions or interrupt me, but otherwise I'll just go on this monologue. And we've done well to some degree, because we've managed to do some really amazing things, and we've managed to work innovatively with the capacity that we've had. We've managed to risk stratify tumors and risk stratify patients, and we have had to do certain things to limit the risk of COVID to patients as they come into hospital. And here's a prime example. This is a huge kidney cancer, and you can appreciate this. I don't know if you can see my mouse, but this whole thing is a huge kidney tumor that's in a patient that's from up in Birmingham, and he has got all this tumor going down his one of the main blood vessels that takes blood back to his heart, called the inferior vena cava, and a big bobble that's sitting in his heart. So this is the kind of surgery that, if you don't do now, it's imminently life-threatening. And it's all been about trying to determine which patients are low risk and which patients are high risk. And I'm going to come out of the slideshow now so that we can make this a little bit more interactive. But what we've managed to do are set up surgical hubs. And these surgical hubs during the crisis of COVID would basically you would have independent bodies, independent practitioners who would determine whether cases were more urgent than the others, because often what you'll find is there's a lot of fighting between surgeons to get things done. And so that led to a little bit more transparency. We've learned a lot about COVID as we've gone through things. We've learned about the disease, we've learned about our mortality rates from COVID, and we've learned about its impact on patients in particular. So we know which patients are particularly at threat if they were to undergo, for example, thoracic surgery for lung cancers. If these patients got COVID, they're at significant risk of death versus other tumors. We've learned how to manage patients. So we know that and many of those people who've got relatives who are due to have operations, the instructions are you need to self-isolate for 2 weeks, you and your family members, because if you were to self-isolate, the chance of you getting COVID before an operation is less than 5%, and therefore there's a significant has a significant impact, particularly when the sensitivity of the tests that we use are not perfect. And we're trying not to put as many people to sleep as we possibly can. If you can get away with an operation that can be done under a spinal anesthetic, so you're awake, so you don't push the COVID bacteria, COVID virus, down into your lungs by artificially breathing for people, all the better. So, and we're constantly reevaluating this with the audit trails and reporting back to NHS England about how our cancer statistics are going. But there is no doubt there is currently a knock-on effect, and it's a huge knock-on effect because not only do delayed cancer waiting lists impact on patients, which is so important because they struggle both physically and emotionally and psychologically, but it has a knock-on effect on those people who are on routine waiting lists as well. And routine waiting list doesn't just mean, I may or may not need my hip or knee done. It means people who are struggling with catheters or tubes in various places and waiting for surgical treatment to correct that. And so it has a huge impact on their quality of life. So I'll stop there for now.
No, thank you very much for that. We've heard in previous forums, Raj, about how hospitals have cut through red tape and bureaucracy to get things done at a much more rapid pace than before. So from that perspective, how the last 20 weeks impacted you there? Has that accelerated cancer innovation and treatment development in your world, or has it held it back?
Yes. In fact, there was a huge. The National Health Service is well known for having a huge amount of red tape and bureaucracy, and it takes about 20 steps to get one thing done. And one of the most useful things that have come out of this is probably through NHS IT or their information technology group, where they've basically said it's rather than going through all the red tape to get something that's wholly GDPR compliant and ticks every single box before we implement it going. We're going to just put a hold on that for the next, I think it was 20 weeks at the time, and just say, you go for it. If it gets the job done, just go for it, and we'll deal with the rest later. And that has been hugely helpful, actually, in that we have then been able to bring in a huge host of technology, particularly surrounding virtual clinics, being able to see patients in a safe way, being able to communicate with patients in a safe way and their relatives, and actions. And a prime example is how in our intensive care units we're not allowed to have visitors. We're not allowed to have patient family members even speak to their dying, relatives or see their dying relatives face to face, because it's just too much of an infection risk. And it's about bringing a system in that clearly, very much like Microsoft Teams or Zoom, but just to allow patients to connect with their family member through their last days. And that's been so powerful for the family. And the same thing goes for cancer care. We've been able to do consultations with patients and their family members virtually. And some people are isolating up in Manchester, some people are isolating down in London. Their mother sitting in Sidcup, and we've managed to connect everyone together on a phone call, so they're all participating, and that's been really, really useful. Certainly, there's been a lot of talk about, do you lose the human aspect of a consultation when you're having a face-to-face, when you're having a virtual meeting? There is something to be said there. There is something that's very powerful about reading people's emotions and touch, and just, you know, the odd head nod, and all these things. They're very, very powerful. But actually, there's a lot of data to support the fact that patients do prefer virtual consultations, and they definitely do prefer virtual consultations when there's a pandemic, because they don't want to come into hospital and contract that. There is also some data to say that they don't like seeing doctors with masks on them, speaking to them, because you just lose that. The moment you can't see someone's face, you lose so much in terms of expression, and it's all about trust in this business. And a lot of what we do is, inspiring trust amongst our patients, and seeing someone's face is very powerful for that.
Absolutely.
So yeah, we've also changed the way we've managed our just our flow of patients into hospital, because we've had a lot of patients that aren't allowed in. We have a capacity as to the number of people we can see in our outpatient centres, so we have switched a lot to virtual follow-ups. But we've also managed the flow of patients through the department a little bit more effectively. Do we really need to see someone? Can we follow them up virtually? Do they? How many people do we need? How many times do we need to bring people in for results and scans? Can we get it all done the same day? So there's been a lot of work that goes around trying to schedule people so that they don't come in for an appointment, then come back in for a scan, and then come back in to see the doctor for the scan result, and then come back in for an operation. In terms of exposure to COVID in the healthcare premises. So we've tried to rationalise on that a lot.
So Raj, I think a lot of what you say there, I'm sure that Trish and Jess are going to, will resonate with yourselves, and I'll come to you in a minute just to kind of reflect on some of that. I'd like to bring Bob in, if I may, Bob Andrews from Benedine Health, just to expand on some of those points. Because Bob, from your perspective as a mutual society providing private healthcare to almost 1 million people and being the CEO of that, what's been the impact on COVID in your world for the wider availability of healthcare services as well as waiting lists?
Yeah, it's well, as Raja said, it's been an interesting time, hasn't it? And just for context, what I run is an organisation that's been around for 115 years as a not-for-profit mutual, providing healthcare initially for tuberculosis for postal workers. So you kind of have that respiratory kind of link. One of the things we also have is an outstanding hospital, CQC outstanding hospital in Kent. So I've had sort of experience through both as a healthcare provider, if you like, as an insurer, but also very much as a hospital as well, sort of sharing some of Raj's experience. And we use, outside of our own hospital, we use the Bupa network and other partners like Vita Health, Medical Solutions, Grace Consulting, so organisations who are dealing across the country with different aspects of health and well-being. I think that, since whatever that infamous day was, sort of lockdown on the 23rd of March, clearly the NHS focus had to be all about COVID-19. And through that process, then private capacity was acquired and focused on trying to support the pressures that the NHS had, so that we could really get COVID on top of COVID. The building of the Nightingale hospitals, which fortunately in the end weren't really used that much. I mean, that's kind of great, but no one knew what was going to happen going into this. And the consequence of all of that was that the non-urgent elective surgery basically stopped on and around the 23rd of March. Then what you also had was effectively the general public generically ceasing to operate normally on health issues. And I think, as Raja said there, there's people who have potentially ignored symptoms and ailments. They've stayed at home instead of trying to get help for potentially life-threatening issues, which have then gone undetected. And that's despite actually GPs being open and hospitals having COVID cold sites. So I think, you know, anyone who's been into a hospital will know that there is, you know, they've worked really hard to make sure that there are clean areas and then you get the hotspots to make sure there is some ongoing support for healthcare. That said, there are some activities, and I think endoscopy generically, for instance, has not been a diagnostic that could be used during this time period, and that's quite an important one, particularly, I guess, in the cancer care environment. And that has meant, again, that people who were on regular reviews, if you like, as part of their ongoing monitoring and treatment, haven't been able to have the kind of support that they might otherwise need. And all of this really means that we've got people living with potential issues that are, as I say, either not being treated or are undetected. And I mean, all of that kind of, when you come back to wait lists, and, you know, there's various numbers that are talked about wait lists, but, you know, going into COVID, the generic wait list was circa 4 million. Coming out of it, it'll be circa 10 million people waiting for some kind of treatment, support, investigation. And then you couple that with some efficiency challenges, testing and PPE to the costs of the whole thing. And when it comes to efficiency, I mean, it's interesting. I think Raj was alluding to the fact there are actually some opportunities through this, and I think that kind of whole remote consultation piece is absolutely, why not? You know, you know, if you can do that remotely, and I know GPs and consultants are doing a lot more of that work. But when it comes to surgeries and theatres, there are rules that are being developed, and I say being developed because there seems to be some very, you know, it's as ever, we try to provide guidelines and rules, and then how do you interpret them? But, you know, you have a certain period of time with which the air in a theatre needs to be cleaned, and with the scrub downs, etc. And that means that you can't necessarily be as efficient with the throughput of the patients, which means that whilst the hospitals are there and people want to support patients, you just can't do it as effectively and efficiently, and all of that is going to impact on the wait lists and availability. And I think part of the process as we've been going through the last sort of 4 months is the health providers, particularly in diagnostic and treatment, have been looking at the prioritization. So trying to ensure that those that are really life-threatening do get the support. As I say, that's providing they come out of their homes to come and find it. And then all the way down the prioritization list to the, you know, I've got a bunion that needs to be removed, well, kind of live with it and we'll deal with that later, kind of thing. So and there's also differences across the country. Clearly London and the southeast has been more greatly hit, I think, than the north. And if you go to Northern Ireland, it's actually been, you know, moderately quiet. I mean, you know, relative to parts of the UK. So one of the things that is, you know, when we went into it, as I say, the NHS England secured a contract. This is an absolutely unique contract with the Independent Hospital Providers Network to provide capacity from the private network, and basically it kind of closed the private network. That now is unwinding, and so in terms of delivery of healthcare, we're starting to see, you know, ability to support. But there is a new contract that NHS England, rightly, I think, is looking to work with the Independent Hospital Network on, which effectively will take 75% of the capacity between 9 and 5 on a Monday to Friday to try and support that 10 million wait list that I was talking about. So you can see that the impact on availability has been quite dramatic, but it's probably come across as being even more dramatic because even that availability that was there, people were not taking advantage of. Yeah. And I think from a clinical point of view, and you know, I think there is a degree of frustration probably that people stayed at home when they should not have been staying at home, and that's going to impact in the longer term.
Bob, thank you so much for that. And you said an awful lot of things there, which I think some of those facts may be of surprise to people in terms of the size of the waiting list and that new NHS contract. And I would encourage people to to please ask the questions as they come through. I would like just to bring in Trish and Jess from Maggie's as well, just to open up the conversation a little bit more, because you've highlighted a number of points there, Raj and Bob, about almost kind of from the front line of medical care and cancer care. Trish and Jess, from your perspective and the work you do, and the very important work you do, which is outside of the NHS, with a focus on COVID, maybe starting with yourself, Trish, over the last 5 months, what's been the impact on that, the cancer care that you then provide within Maggie's?
Yeah, thank you, obviously, for inviting us to this forum. It's had a huge impact. I mean, obviously, when COVID started, we went into lockdown, and a lot of the centres had to shut their doors because we weren't able to provide that support that we normally do. Maggie's ethos is that we support anybody affected by a cancer diagnosis, their family, their friends, their next door neighbours, their work colleagues, and we're able to give them that immediate support. And that's where we differ from other cancer charities, because our doors are always open. You don't need an appointment, you don't need a referral, and you can walk into any Maggie centre across the country and access that support whenever you need it by professional people. So for cancer support, for benefits advice, for psychological advice. So we provide all that emotional, practical and psychological support. So when COVID hit, we had to look at how we could still provide all that support, but in a slightly different way. So even though we had to shut our doors, we were still able to provide that cancer support over the phone, virtually, or our online community. But it did hit really hard, and the conversations that we were having with a lot of our centre visitors was about their treatment had been stopped. Heartbreaking conversations with relatives and with centre visitors that were on treatment, because the risk of them continuing with chemotherapy would have put them at such high risk. So at that time, when somebody has a diagnosis, they're on chemotherapy, that you would hope that would potentially extend their life, knowing that their chemotherapy was stopped or any other treatment was stopped, when they're supposed to be spending time with their family, making the most of the time that they have left, they were unable to do so because of shielding and because of isolation. So that's had a huge impact, sort of like emotionally, for people. People are very angry. They feel as if they've been robbed by COVID, because decisions about their treatment, the time that they want to spend with family has been taken away from them, and they've not had that decision to make. It's been taken away. So the conversations that we've had over the phone with people and virtually, as much as we can, has been trying to support those people, and regular visitors that we'd have to the centre. We would, keep in touch with them just as a check-in, because isolating and shielding is very frightening. If you're on your own, you're not allowed to go out through the front door, can't go shopping. And the community, I think, has been sort of like hit really hard. So those visitors that would normally have community support, that's not there anymore. We've had, bereaved people that have unfortunately not, have cared for their loved ones at home with no community support, just that support somebody over the phone. And that's heartbreaking. It really is heartbreaking. And I think because Maggie's isn't clinical, even though we're on the grounds of a hospital trust, we work very closely with the clinical teams. People are worried about their follow-up program, they've not had a call from the clinical team. They're due to have a scan in a couple of months or have their bloods done. And, you know, they understand that they can't come to the hospital, that those investigations are sort of like on hold. But that anxiety is huge. And even those people that I think we are going to have this huge backlog and this huge amount of people that at a time where, say, they had symptoms of a cancer, is they haven't done anything about it because they haven't been able to get to the GP. So if they were diagnosed at that point, you could be talking about a potentially curative, you know, cancer diagnosis. But now that if they go now, that could end up being now a palliative, or, you know, no treatment can be offered. So a lot of the, as I say, a lot of the conversations that we've had, and Maggie's also provides a program of support as well. So we look very closely about health and well-being and sort of helping people make choices about their future. So some of the group works we've had to go virtually, like sort of exercise and, you know, and things like that, and support and bereavement support. So how we've changed is very different, but we're quite proud of the fact that we've still been able to provide that support as best we can, but just in a slightly different way.
No, absolutely. And I think, Trish, you touched on a point there about, you know, your resilience and your innovation that you've applied there, which has been so important in terms of how you've had to adapt to those circumstances. I mean, Bob mentioned that as well around, you know, the virtual consultations and the Raj, I mean, from your perspective as well, are some of these innovations that we've seen over the last few weeks, are they going to stay? And how does the NHS maintain this spirit of innovation and pace of innovation?
No, absolutely. I think they will stay, actually, because they've I think there are a lot of things that we're just going to accept as the new norm now, to be fair. I think we're all experiencing it in our day-to-day lives. I mean, Protiviti, for example, from what I understand, I'm pretty sure hardly anyone's going into the Shard or any of your offices at the moment. And I think we're accepting that virtual working is going to be a part of our day-to-day life. And that's great in the sense, because a lot of people do prefer that. I think the same thing will happen in medicine. I think we will see, I mean, one of the worst feelings I had was walking out, having seen a patient in a clinic room, and then walking out to see the sea of angry faces waiting because you're running an hour or 2 hours late, because that's just the nature of your national health clinics. You know, and to have now just be able to know that there's only 5 or 6 people that you've called in because of the most essential people that you've called in, and then have and then if you have time for a very reassuring or, you know, purposeful chat, you know, virtually, that sometimes patients do prefer not coming into hospital at this particular juncture. That might change in the future when we see a flip side to things, but I suspect that this will stay. And I think we need to capitalize on a lot of innovation now within the NHS. I think you know, Bob, your point on how to manage theatre efficiency is so critical. You're absolutely right. If there is ever a time now to really capitalize on how operating theatres work, it is now. And the reason is it costs the taxpayer £8,000 per minute to run an operating theatre. £8,000 per minute. And that's just taking into all the costs of staff and rent, you know, the occupancy, and yet, you know, time after time to get our first patient down into an operating theatre because of delays on the ward or X, Y, or Z, it happens routinely. And so we need to be innovative with our timetabling. You know, it may be an opportunity to say, look, actually, do you know something? Maybe 9 to 5 isn't the right way to run theatres now. Maybe we need to think about different shifts. Maybe we need to have a group of people starting at 5:30 in the morning and finishing at 10, and a group of people starting at 10, finishing at 4, and a group of people going on till 9. Because unless you use your capacity efficiently, we're going to still keep playing catch up.
I agree with that, Raj, and thank you. I'm very keen just to bring Neil in as well. And Neil's been very patient. Neil, we've had a lot of challenges there. and as a company that specializes in using data to make the right decisions, in your mind, what's the opportunity for maybe using better data to lead the response to COVID and address some of the challenges that Bob and Trish and Raj have mentioned, and maybe even wider diseases as well?
Thanks very much, Paul, and thanks for the invite this morning. I think there are a huge number of opportunities of how we can use data. You know, Raj touched upon how you can prioritize patients coming in, how you can manage those patients through the system, but there are also fundamental opportunities around how you understand the disease and manage the disease in this context. You know, a lot of the current strategies around SARS-CoV-2 are focused on reducing the risk of infection rather than managing patients in the right way once you know the patients that are going to have a severe incidence of disease. There's been a lot of talk about comorbidities, so things like obesity and diabetes, and characteristics such as age and ethnicity that appear to confer a significant risk from infection. But when you actually look at the numbers, you know, the prevalence of those things across the population, it is clear that there is still something that turns someone that could have severe disease into someone that will have severe disease. And it's understanding what that molecular switch is, if you like, that would allow us to get to some sort of prognostic that means that when someone turns up at a hospital showing symptoms, there is an understanding likelihood that they're going to have severe consequences from a COVID. And we're involved in a consortium that's looking at some of this stuff in terms of trying to identify that metabolic signature, if you like. We've already done a wide-ranging meta-analysis that looked at indicative pathways and markers that could be the underlying cause of this across those populations that we're talking about. But it's a very, very complex problem. What you're talking about here is not just about comorbidities, so other diseases that people might have, but how well managed are those comorbidities? So there are indications that if you have undiagnosed diabetes, then you're going to have a much different experience with a COVID infection than if you've got a well-managed diabetes. So there's a lot of work to be done there, and it is a very, very complex issue because you've got not just clinical factors involved, but you also have societal factors in terms of those sort of demographic issues around ethnicity, age, living conditions, and so on. And when you start layering those on from a data perspective, that becomes a very complex challenge. So we're currently working around that, looking at getting some of that work carried out, and then taking the output of that and layering that with some work that's going on at University of Nottingham. They've got a prospective study looking at healthcare workers with COVID infection and monitoring them in a very detailed way. So they're taking lots of samples that allow them to look at blood markers and the like in those healthcare workers. And we can then overlay that on what we're seeing from the real world data perspective and potentially come up with that answer that gives us that better prognostic. And what that prognostic allows us to do is take a lot of pressure, you know, in a situation where we still don't have a vaccine. Anybody that knows anything about vaccine development knows that the likelihood of having a vaccine in short order is pretty low, despite all the great efforts that are going on from people like Moderna and AstraZeneca and so on. It is still the case that we need something, particularly amongst in the population, that we need something that is going to allow us to better manage patients as they come through the door.
Okay. Neil, thank you very much for that. I don't know if it's just me, but there's a little bit of lag on some of what you're saying there, and it's coming through a bit strange. So it may just be worth turning your video off at some point when we do it again. But I'd maybe like to take some of those points back to maybe kind of Raj and also to Jess, because Neil speaks about a lot of things about innovation, about data-led innovation. But of course, from your perspective, you require funding, and I imagine, maybe Jess, if I start with yourself, there's been, funding has gone in other directions recently, so you are wholly reliant on the public purse and the generosity of donors. I mean, how has that changed over the last 5 months?
So, like you said, we do rely completely on the donations of our communities. So at the moment, we're looking to be around £7 million short of where we need to be at the end of this financial year. So the main reason that's happened is because of events not being able to take place. Our corporate supporters have been adapting to different ways of working. Again, some of our businesses have been hit also financially. And there's just been a general period of uncertainty, which has made people be a little bit more cautious with their cash, essentially. But we've had to really adapt to new ways of working. So we've looked at taking our events online, encouraging people to still fundraise on their own, encouraging our corporate supporters to fundraise virtually with their teams and their employees by doing things at home, and really just having to sort of go back to basics, strip it all down again, and relook at the way we work. And it's not been easy. And like I say, we are looking at a £7 million deficit, but we're working to make that not as big as it sounds, but it's still a real period of uncertainty for us. And like Trish said as well, we're finding that the people that are coming through our doors are people that really need psychological support at the moment because of the fact that their diagnosis has been impacted, and the fact that we can provide that as soon as you walk in our door, and we have no waiting lists or anything like that for psychological support. You can just come into our centres and get that, is really key as to why we've been really pushing that we need to still be there for people, because we aren't like anybody else. We just provide support that isn't out there, that you can't get instantly like you can do at Maggie's. And even if you don't want to come into our centres at the moment, just pick up the phone and someone will always be on the end of the phone for you. So it's been tough, and Trish will relate because Trish works really closely with the fundraising team as well. But we're getting there, and we are starting to see positives coming back in, and organisations, starting to look at charity work again. And lots of our sort of friends of the organisation have been incredible in saying, no, I know you need your support at the moment, I'll give it to you, but it's not easy, and the £7 million is quite a task, but we'll get there, I'm sure we will. But it's not been easy, and new ways of working have been a challenge, but we're all learning from it. So
absolutely. So
can I just say,
of course, really.
a lot of our centres are now open, so we've opened our doors, yes, with the restrictions by the government, but the buildings in themselves are so important to people's well-being and support, and that space that we give people in the centres is that calming environment where they can express themselves freely, and there's no judgment. And I can't stress the importance of having that face-to-face contact, because it is so important. People are more open in how they feel. So we've been open now since the 1st of June. We opened our doors to sort of appointments and drop in and things like that, and things are picking up, and we're really glad that we want people to know that Maggie's is a safe place to come. So as they're starting to come out of lockdown and they want to try and build that confidence up a little bit by actually coming into Maggie's, to know that it's safe will help, I think, people in that adjustment period, that coming to the hospital grounds is not a frightening thing, whether they come on public transport or whether, however they get here. So we want to encourage people to come to Maggie's as maybe their first step back into that life of adjustment, and to say, actually, it's okay. And things are starting to pick up.
So thank you very much for that. I think, yeah, a lot of what you said, I can see from the comments on the side as well. A lot of what you're saying, particularly Jess, around the mental health point, is as Bob says, a bigger issue than ever before. I'd maybe just like to bring all our panelists back then, just with a few questions around kind of looking towards the future. And Bob, maybe if I can come to you first with this. So, hearing from what Neil said from a data perspective and some of the challenges we've heard here today, how can we manage, in your view, our healthcare resources more effectively if we look towards a second spike or even another pandemic? What would you see? What would you want to change? What should we do better?
Yeah, I think it's a great question, because lots of what we talk about is the bad experiences and the difficulties, and I guess the question is, what are we learning from this and how are we going to go forwards more positively? I think from my point of view, better funding and better coordination would be the simple answer. I think that we have missed opportunities. If I think about I mentioned the NHS England IHPN contract. I think that we've missed opportunities. Raj made the comment actually that we're trying to keep the private sector COVID cold, if you like, so that we can get non-elective work going. And I think that's something we perhaps, had we had our time again, been able to do better. So that coordination is important. Yeah, those are probably the two things. I mean, there's definitely an issue of funding, and I think it's. Sorry, go on.
No, I agree.
Yeah, and I think that there is also, and I don't know to what extent the guys working with the NHS would share this, but I think we have at the moment the way that healthcare operates, it's too fragmented. And there has to be better coordination of budgets within regions and across the NHS and the different types of healthcare. There is too much, I think, of I don't want to accept that patient because I'm going to have to start paying for them. So they stay in the wrong place. And we've got to put patients where they're best treated, and that means sharing budgets and taking away some of the targets, if you like, that kind of cause some of this. I'll call it maltreatment, that's probably too strong, but this kind of issue of people ending up in the wrong place. So better coordination, better funding.
Thank you. Neil, if I could come back to you with the same question, please, just around how, in your mind, then, should we be looking to more effectively manage the possibility of a second spike or even another pandemic?
I think there's a lot that can be done. From the data perspective, there's a lot that can be done to help support this, as we were talking about. But one of the big challenges within healthcare and data is availability of that data. And particularly from, Raj touched on GDPR earlier on, particularly from the GDPR perspective, there's a very striking difference between the approach in Scotland and the approach in England, where in Scotland it's an opt-out for patients in terms of data sharing, whereas in England it's an opt-in. And so that we're trying to do around this, the quality of data that you see coming through to enable some of those studies, and we've done things in mental health and cancer previously, is a challenge. There is no doubt about that. And it's also the ability of being able to unlock, for want of a better description, citizen science that allows businesses to support a lot of what's going on in the public health environment, and make sure that we can make those differences across not just pandemic infection, but across other diseases as well.
No, thank you for that. Raj, if I could put the same question to you, please, and just from your perspective, how should we change? How should we get ready for anything that's coming over the hill here?
Yeah, I think there are a few things. One is they're probably threefold. One is managing your resources, your actual infrastructure properly. If you can understand exactly what is available, get it to speed. I mean, what we've suddenly found are operating rooms or clinic rooms or facilities are suddenly not fit for purpose because of various air ventilation issues or not enough high dependency beds. we need to have an escalation process that you can act on very, very quickly. And I think we've learned that very, very quickly, actually, now what works, what doesn't work. So next time round, we say, well, actually, hang on, let's not do that because it completely flopped. Or we need to have X, Y, or Z in place now. And I think a lot of institutions are understanding this. So infrastructure. 2 is your staffing levels. It's a huge burden, both physically and emotionally, for nursing staff in particular, who bore the brunt of looking after COVID-19 patients. And I say that as a plug to my wife, who's an intensive care nurse, actually, who was looking after these guys. For those few weeks, I could not come home and say my day was worse than hers. It just never was. And I think these guys, they need to have the requisite rest and then recuperation, because next winter something will happen, whether it's COVID or a big flu spike or something. We will see. We know from pandemics they tend to come in waves of 3, and so I think you need to have your staff rested, recuperated, remunerated, and then have the energy to then take on the next fight, because otherwise they will leave. And the moment they leave and they're disheartened, you have no healthcare service.
Yeah.
And probably the third thing is to learn from the disease. Your points earlier were absolutely right. We need to learn from the disease using the data that we have. And if we have that data, we need to make it freely and publicly available. And use organizations that have much like yourselves, who have better skills in understanding and interpreting data than we do as clinicians, to help predict trends, to predict how what things work, what things don't work, and use that data in an effective way, so that we can be a lot more targeted in our approach, rather than being very much because right now it's all been kind of, everything's been thrown at it, but actually only less than half of it's been really effective. And I think that's where data will be so powerful there.
And we heard that Jess mentioned that they're 7 million down because of COVID. Presumably that affects your world as well, in terms of your ability to conduct innovation, conduct research.
Yep. Without a doubt. It's been very interesting how people have been funding charities at this particular point in time. And do correct me if I'm wrong, Trish, but the moment there's if there's a campaign for something, then often it triggers an emotional response that results in a donation. And that's why often these TV campaigns work very well for various things, like for hunger campaigns in the developing world, or whether it's to help feed starving cats or dogs. They play on an emotional response there. But the emotional response in the media, the emotional sort of response that's being hit in the media, has completely been towards COVID, and therefore a lot of the donations that have been out there have been very much geared towards funding COVID-related things only, when we know that the government are already ploughing in a lot of money towards COVID-related activity as it is. And it only means that there is going to be a shortfall in everything else that also matters. And I speak from a cancer perspective, and certainly I use a lot of the guys in St. Thomas's charity funding to help fund a lot of research work that we do in terms of moving things forward, not just from a biochemical and pipetting level for treating cancers and moving, but also from a logistical pathway. How can we make the logistical pathway of a patient from point A to point B very effective? And that's what Productivity has been so helpful with. And a big shout out to Neil for this. Is that we've used your skills, and we've used the donations that you've helped in order to move to make the pathway a lot more streamlined.
So Raj, thank you ever so much for that. I'm just aware of the time, and I just wanted to come back to Jess then. Just let Jess have the final word. So Jess, you've got a bunch of business leaders here, and I wouldn't be doing my job if I didn't give you the opportunity to say, so at this time, 7 million down, what do you, speaking on behalf of the charity sector, if that's not too big a role, but to say, what do you need from corporates at this time? What can they do? What can corporates do best to support you?
So forgive me for being blunt, but we need cash. That's what's going to keep our centres open. That's what's going to keep these charities afloat, and charities that do provide vital services that, and I speak on behalf of Maggie's here, you can't get anywhere else. And without Maggie's, all those people that need that psychological support and somewhere to go to talk to, they're not going to have that, and we're back to square one, where people are sat in their cars in a car park having a good old cry about the diagnosis that they've just received, and not being able to come into our centres and speak to a healthcare professional and get that much needed support. So it is cash, but there's ways of doing that. That could be through corporate donations, that could be through encouraging employees to fundraise, setting up charity of the year agreements, and we can work with you as well. So we know at Maggie's that it takes a lot for an organisation to support us and rally round and get their staff on board too. But also what we can provide is that you can direct your staff to us if they're struggling, if they're going through a diagnosis, or a friend or a family member is, send them our way. Tell them to pick up the phone, tell them to pop into our centres, and we'll help them. And also we can come into your workplaces and provide support and training, so that you've then got members of your teams equipped on how to support people. One of the biggest questions we get out of our corporate supporters is, so if my colleague that I sit next to in the office has cancer, well, what do I say to them? Is it a right thing to say? Is there a wrong thing to say? And we can help give people the confidence to have those conversations, but also be there to support employers and give them a bit of confidence to say, go to Maggie's and signpost them to us. And also, as an employer, you can pick up the phone to us and we can help you look at all the different ways of working and everything like that.
Jess, thank you ever so much for that. Really appreciate it. As ever, we've run out of time. I'm going to get told off by my colleagues because we've overrun slightly. But thank you ever so much to all our panelists today for your perspectives. Really, really grateful for you taking the time. This isn't quite the end. As we've done other weeks, we're going to keep the line open, and you're all very, very welcome to join us if you can spare the time to keep the discussion going. Next week, we'll be looking at the future of business. This is our 20th session next week, and so we'll be doing that. And then we'll tell you a little bit more about how we're going to slightly alter the format over the summer months, or over August and September. But at this point, I'd like to thank our panelists once again for the day. Thank all of our attendees. I hope you found it, an inspiring session today, and giving you those new insights around some of those challenges right on the front line. Hopefully, I got to most of your questions, and apologies if I didn't. But we sincerely hope this forum has been useful for you today, from your own personal perspectives as well as your business perspectives. So, on behalf of my Protiviti and Robert Half team, would like to extend our best wishes to you all. Stay safe, be kind to each other, and we look forward to catching up again next week. So, thank you all very much, and we'll speak soon. Thank you. Right, so at this point, yeah, we still have a number of people on. So as I said, this is a more, however you wish, really, a bit free for all. But Anne, I think I can see you on my screen now. I think you had a question you wished to raise, Anne. I'm sorry, you're muted at the minute, Anne. I still can't hear you. You're still showing us muted. Let me just try and unmute you. Oh no, I can't.
Okay.
Oh, there you go. Yeah, I can hear you now.
Thank you. I've been a member of a patient group for a long time. Oh, just lost you on here. And we've been really conscious as business